we'll cover the content, whatever we are going to cover. So, quick recap of the thing, whatever we are studying so far in abdomen. We are studying through this abdominal cavity, and this particular abdominal cavity have got a covering which is a membranous covering. We call this membranous covering as peritoneum. It has two layers. We agreed on it. Having these two layers, we have to name separately, as we call them as parietal layer, which is covering this body wall, inside of it diaphragm and this pelvic cavity, and other layer we call them as visceral layer, which is covering the organs which is present on it. Now, this particular parietal layer and the visceral layer have got different innervations and the blood supply accordingly, as this particular organ is, as basically this particular covering is covering this parietes or the viscera. So, if it is parietal peritoneum, which has got like a numbers of this particular somatic nerve which is supplying to it, whereas this particular visceral peritoneum is supplied by this particular nerve, we call them as autonomic nerves. Now, this particular autonomic nerves cannot feel the pain, and it is, that is why it is called insensitive to pain, but that does not mean it feels nothing. It feels any other sensations, but the pain receiving receptors are not there. Now, this particular peritoneal space have got cavities inside. This cavity which you see here in the abdomen, once you get into the abdomen, we call them as greater sac. Other than this particular greater sac, we have this particular small modifications or small pouch of this particular peritoneum cavity is there, we call them as lesser sac. So, we will talk about greater sac, lesser sac as we progress through this content. Now, we move to this particular peritoneum, as peritoneum, based on how this particular peritoneum are covering or placed, we call these organs or intra-abdominal organs into two categories. Either this particular peritoneum covering it completely, we call them as intraperitoneal organ, which is wrapping this particular peritoneum completely, and it may be lying behind this particular peritoneum, we call them as retroperitoneal. This retroperitoneal may be primary, secondary. That means it was initially interperitoneal, then later on it has moved to the posterior abdominal wall, and that makes this particular thing secondary retroperitoneal. Just like in case of this duodenum and the pancreas, that paste it to the posterior abdominal wall, that is why it becomes loses this peritoneum, we call them as secondary retroperitoneal organs. And this particular peritoneum have got some modification, that is what we talked about. Now, this particular modifications of the peritoneum, we have to pay close attention to it, because these are exam questions, that is why you were learning this. So, we have some kind of changes in the peritoneum. So, there are so many changes are there. So, some changes are categorized together. So, some of the changes we call them as like peritoneal reflections. Just like peritoneum is imagine just like a light source is falling on some wall and moving up and down based on this particular organ how it is going. So, this particular changes on the course of the peritoneum as it is hitting the organ moving up and down, we call them as peritoneal reflections. So, we have to know what are the peritoneal reflections to be sure, and what are the basically important part on these peritoneal reflections. Some of the peritoneum have got something which is coiled that looks like a ligament, we call them as peritoneal ligaments. So, you have to know what are the ligaments are there in the form of or modified form of peritoneum, we call them as peritoneal ligaments, and what do they serve us. And some of this peritoneum have got some kind of bends or folds, we call this as a peritoneal folds. So, we may be this peritoneum fold present in the abdomen cavity, may this particular peritoneal folds present in the pelvic cavity. Based on that, we are going to talk about this, and we have this particular peritoneal space which is divided into subspaces like greater sac, lesser sac, paracolic gutters, etc., etc. Subsequently, we will talk about it. So, we started this peritoneal reflections. There are so many peritoneal reflections are there. So, you have to know what are the different peritoneal reflections. So, individual peritoneal reflections could be your exam questions, and asking about the different peritoneal reflections and narrate this peritoneal different reflections and the importance to it. So, there are several peritoneal reflections. We started with the greater omentum, lesser omentum, mesentery, transverse mesocolon, sigmoid mesocolon and mesoappendix. So, these are known as peritoneal reflections. So, we take it one at a time, like talking about these peritoneal reflections. We talk about this greater omentum, which you already have seen this in the dissection as well. It is hanging from this greater curvature of the stomach, hanging down like an apron, and this particular thing holds this particular peritoneal fold along with these fatty tissues, blood vessels, etc., etc. So, this particular greater omentum have got like as a content, we see that there is a number of blood vessels present in that, and this particular blood vessels we call them as omental vessels, and out of that in this region we have this anastomosis of two arteries there. We call them as right gastroepiploic or gastro-omental or left gastroepiploic branches which are coming in here, which is branches of the celiac trunk which is arching around this greater curvature and heading here, and from there are the omental branches which is falling and dropping down. So, this is the content of this greater omentum which is present in it, and apart from that, greater omentum itself has a point of interest. We learn about this particular greater omentum has a capacity to move elsewhere within this particular abdominal cavity if you have any sense of infections there. He tries to localize the infection, that is why you call this as abdominal policeman. If you have any infections any place which is placed in the abdomen, this particular peritoneal fold greater omentum moves to that side and tries to limit the infections in that particular region, just like in police people. So, that is why it is called as abdominal policeman. So, you have to justify, explain why kind of questions, why this particular greater omentum is called as abdominal policeman. Other than this greater omentum can be used for several other issues as well. So, during surgery we use this particular omentum as a omental patch. Say for example, if you have stomach has perforation, we can use this particular omentum to repair this particular content as well. This particular omentum can be used for repairing injured liver tissues, splenic tissues if it is there as well. So, this particular omentum serves a large amount of functions in this particular region. Surgical use or this particular thing may have some additional use, just like plugging this particular hernial sac. It tries to prevent the herniations as well. And sometimes during this particular course, as it is moving through, it may be have some kind of like a torsions or may have some kind of bends there. So, which is known as the torsion of greater omentum. That torsion of the greater omentum or twisting of this greater omentum seizes the blood supply within it and creates a lot of pressure or peritonitis or peritoneal infections or inflammations like that. So, this particular omentum, greater omentum has a great importance and has got clinical significance as well. Coming from this particular greater omentum, we are talking about the lesser omentum. This particular stretch of this omentum is extending from the liver under surface to this particular lesser curvature of the stomach. Now, if you just like a dig here on the liver where it is attached, the point where it is attached on the liver, we call them as porta hepatis. In the porta hepatis, we have a groove, we call them as groove for ligamentum venosum, which is a developmental remnant. So, in this particular liver region around this porta hepatis zone of this particular liver and ligamentum venosum groove, this particular lesser omentum is anchored and attached. Other attachment is on a lesser curvature. So, it is hanging like there and it is falling on this particular anterior wall of this particular lesser sac. Now, this particular omentum you can see that is falling on two aspects, from liver to the stomach and liver to this particular duodenum. This particular entity splits this particular lesser omentum into two segments. Segment 1 from the stomach to this particular liver, we call them as hepatogastric ligament, and zone 2 which is falling here from this particular liver to this duodenum, we call them as hepatoduodenal ligament. Now, this hepatoduodenal ligament, you see that this margin is free, we call them as free margin of lesser omentum. So, this margin we call them as free margin of lesser omentum. So, this free margin of the lesser omentum just like gives a space or gives a kind of like a tiny slit, so that from this particular sac which is greater sac, we can enter through this opening to the lesser sac which is lying behind the stomach. So, this particular opening which is present in here, we call them as foramen of Winslow, also known as epiploic foramen. So, this particular epiploic foramen will be again coming to our interest whenever you are going to talk about this lesser sac, greater sac. Now, point of other concern is the lesser sac contains the blood vessel in this region. So, we have this gastric blood vessel right side and left side. So, the right and left gastric arteries or vessels are present as anastomotic branch as a content of lesser omentum. So, you have to know what this exactly is and what that particular peritoneum reflection contains out here. So, this is the second element of this peritoneal reflection. Third element, we call them as mesentery or the mesentery. This particular peritoneal fold holds this particular small intestine, wraps this. We have seen this particular LTT as well. So, it enters this particular abdomen and holds this particular area of this small intestine, ileum and jejunum, holding in here, wrapping in coil, wrapping this particular small intestine coil like this. So, if you look close, it has two parts. One is attachment side where it is attaching on this particular areas of the small intestine, coils of the ileum and ileum. This is known as free margin. Other is we call them as attached margin, which is attached on the posterior abdominal wall. We call this as a root of the mesentery, and this part we call them as free margin of mesentery. Now within this particular element we see that there is a branches of superior mesenteric vessels moves in here, nerves and lymphatics present as a contained on this particular region, and we have done the dissections as well. So branches which is going to this particular ileum and jejunum, which is coming from superior mesenteric artery, we call them as mesenteric branches or ileal branches or jejunal branches, depending on how this content is coming on. So this particular mesentery is anchored on the posterior abdominal wall, and the free margin is holding this particular coils of small intestine, and it contains this superior mesenteric artery and its branches to it. So this is this entity of this particular mesentery that you have to keep in mind. Other than this, we have this particular peritoneal fold which is related to this particular mesocolon or transverse colon. So what we call them as, we have this particular large gut split into several components, like we have this particular cecum appendix placed in the right iliac fossa over here. We have the ileum ending here. So then we call this as a ileocecal junction. So after that we have this part of the large intestine, we call them as colon, and it is climbing up, we call them as ascending colon. Then it switches the course and runs in a transverse direction, we call them as transverse colon. Then it makes a bend onto this particular spleen region, and then it drops down, we call them as descending colon. Then it curves into this pelvic cavity, we call them as sigmoid colon, and it is going to drop to the pelvic cavity proper as a rectum, and then anal canal to this particular domain. So this particular colon which is present on the transverse region on into this particular bend here on the liver side, the bend here to the spleen side, we call them as hepatic flexure or hepatic bend, and splenic flexure or splenic bend into this particular stretch between this region, we call them as transverse colon. This particular transverse colon is wrapped around by a layer of mesentery, we call them as transverse mesocolon. So this particular transverse mesocolon, we have seen that blending with the greater omentum. Whenever we are going to see the dissection, doing this dissection, we see this particular transverse mesocolon was blending here, and that particular blended part of this particular transverse mesocolon, we call them as gastrocolic ligament. So where we have this particular colon blending with the greater omentum, we call them as gastrocolic ligament. Again, this is a very important question. We ask this particular gastrocolic ligament. Now there is an importance to it, because this particular gastrocolic ligament, as it is blending with this particular liver, because blending with the greater omentum and this particular transverse mesocolon, we have a number of blood vessels present in here. So if you are going to do any surgery related to this particular point, related to the transverse colon or related to the stomach, we have to be extra careful not to injure the blood vessel that are present in these regions. So this particular gastrocolic part or gastrocolic ligament, which is present in the blended part of this region, holds an important artery, we call them as middle colic artery. The middle colic branch, we have seen that coming from the superior mesenteric artery, runs here and splits into right and left branch, supplies this whole of this transverse colon like a up to this particular like a lateral 2/3 or this particular and 2/3 region, sorry 3/4 region. So up to this stretch, this particular middle colic artery supplies in this particular transverse colon. So this particular gastrocolic ligament holds an important blood vessel, we call them as middle colic vessels. So along with nerves and lymphatics. So this particular content, what do we mean by this transverse colon, what do we mean by the gastrocolic ligament, and as well as what does it contain is an important concern for us. We have to memorize these facts. Moving from here, we are moving to this particular part of the colon which is swinging down and twisting here, we call them as sigmoid colon, and this particular sigmoid colon also holds a narrow stretch of the peritoneum, we call this as sigmoid mesocolon. So it is holding this particular sigmoid colon, it looks like an inverted V-shaped structure. So it looks like a downside V structure holding this particular sigmoid colon, as this particular descending colon twisted here and makes a bend like this, looks like a V-shaped structure out here. We call them as inverted V-shaped, this particular sigmoid mesocolon. Now important content over here, we have seen that this particular inferior mesenteric artery supplies this particular part of the gut with this particular left side, we call them as left colic branch, and the branch of this inferior mesenteric artery drops to the sigmoid side, we call them a sigmoidal branch of this inferior mesenteric artery. So this sigmoidal branch of this particular inferior mesenteric artery is present as a content of this particular sigmoid mesocolon. So, whenever you are going to do any kind of peritoneal surgeries, pelvic surgeries, we have to be careful enough not to injure this. Not only that, we see that deep to there we have this particular bifurcations of this aorta, which is splitting into common iliac right and left, and this ureter on the left side swings and crosses over. So, whenever yesterday I was just like separating this part, I just like removed this particular ureter. So, ureter is this region is very notorious for injuring during surgery. So, whenever you are doing this surgery, you have to keep an eye on this region so that you should not be injuring this particular ureter while handling that. That is why you have to take care of this ureter. Once on this particular root of this V, you see that this is a V, and on this particular V union point you have this particular ureter place. So, whenever you open this abdomen, we secure this particular spot, identify the ureter and save this, and then we continue doing the surgeries. So, while you are doing surgeries, you have to know what are the points that need to be taken care. So, this is one whatever you have to take care. Then you have to secure the ureter first, then you have to see these particular sigmoidal branches and you pull aside and do the surgeries. So, this is the thing that you have to keep in mind regard to this sigmoid mesocolon. So, what exactly it is? Peritoneal fold holding this part of this particular large gut and contains what? Sigmoidal branch of inferior mesenteric artery. That is what you have to keep in mind. So, the last part of this particular peritoneal reflection, we call them as mesoappendix. So, it is a small narrow stretch around this particular appendix. So, we have this particular cecum, we have the terminal portions of the ileum there, and at that particular ileocecal junction posteriorly we see that this particular tube existing here, narrow slitty tube, we call them as appendix. Now, this particular appendix is hanging through this particular terminal part of the ileum through this particular narrow strip of the peritoneal fold. Now, this narrow strip of the peritoneal fold is immensely important. Why? This narrow strip of this particular peritoneal fold, we call them as mesoappendix, holds this blood vessel which is going to supply this appendix. Now, why it is important? Because appendix is a very prone to have infections. Particular appendix, if it is infected, we have to throw these things out, you have to do surgery or appendicectomy, you have to remove that. So, if you have to remove that, you have to stop the blood flowing through it. What blood vessels reaches here? We have to identify this strip. So, if you have to identify this, then we clip this, and then after clipping this, we cut this and suture it and let it go. So, this is how we go to do the surgeries based on this particular peritoneal fold and finding the important arteries present in it. So, that is why in examination we ask these particular questions, these particular peritoneal reflections we ask you about. Describe different peritoneal reflections with importance to it. That means the blood vessels which are present in it as a content, that what you have to keep in mind. Always you have to focus in this particular region. We do not ask you to write a essay or a kind of thesis paper on each of this. One liner, two liner, three liner, four liner conceptual content, which is right conceptual content, is good and fair enough for getting securing 100% marks. So, this particular content of this particular peritoneal reflections that you have to keep in mind. Now, from this particular peritoneal reflection, we are moving to the next form of peritoneal modifications. These particular modifications we call them as peritoneal ligaments. That means these particular peritoneal folds are taking a kind of shape of the ligaments, but truly they are not ligaments, they are false ligaments. So, some of these particular peritoneal folds are present in some of the regions that is having some kind of contents there. So, all this again, peritoneal folds, peritoneal reflections, peritoneal ligaments, the point of concern is that they hold some important thing. That is why they are numbered out, that is why they are important for surgical interventions, and that is why they are prone to have chances of being tested in examinations. That is why this is the area where we hit, because commonly while you are going to do any practice, medical practice, surgical practice, obstetric practice, any practice, this particular region where you have to be careful to identify the structure to carry on the surgeries. So, this particular peritoneal ligaments, to start with, we call them as linogastric, also known as gastrosplenic ligament. So, this particular gastrosplenic ligament, split the name, we get this. So, it is a kind of peritoneal fold or peritoneal ligament which is layers, which is existing between the stomach and this particular spleen. Now, which part of the stomach? Stomach have different parts. So, it is stretching on this particular posterior side or upper posterior side of the greater curvature. So, from the greater curvature of the stomach, left posterior part, to this particular spleen, and which part of the spleen? We call them a hilum of the spleen. So, why we call them as hilum of the skin? What do we call them as hilum of the skin? spleen. The hilum of the spleen is that's a doorway through this particular structure gets in and come out, right. So this is what we learn about in this, like a thorax as well, in the lung as well. So hilum is a door through which the splenic vessel gets in, comes out, etc., etc. So between this particular stretch, we have a narrow strip of this particular peritoneal fold, which looks like a ligament. We call them as peritoneal ligament, as gastrosplenic ligament. Now this gastrosplenic ligament is very important, because during surgery for the spleen, so spleen is prone to have injuries. If you have injury to the spleen, it ruptures, and this particular ruptured spleen leads a heavy blood hematoma or blood loss inside the abdomen. So we have to do surgeries related to this particular spleen. Whenever you are going to do the surgery related to the spleen, we have to stop this particular spleen from bleeding. So we have to secure these blood vessels related to this particular spleen regions. Number over here is that during this region over here, spleen contains, or spleen is supplied with the blood through this particular splenic artery. But adjacent to the spleen, we have this particular blood vessels which is supplying the stomach. So whenever you are going to do the surgery to the spleen, we have to secure the blood supply to the stomach, or else stomach will be deprived of the blood supply. So we have to take care of the blood supply to the stomach before throwing the spleen out. So in this region, if you are removing the spleen, spleen has this ligament. What ligament? Peritoneal fold, gastrosplenic ligament. So unnecessarily pulling off this particular spleen from the abdomen without securing this particular peritoneal fold may rip this blood vessel which is present in this particular region. So this is the context of knowing this. So this particular gastrosplenic fold of the peritoneum, we call them as ligament, holds the blood supply, holds this blood vessel, we call them as short gastric blood vessels and left gastroepiploic vessels. So if you remove this particular spleen during splenectomy surgery, you have to secure this splenic blood flow as well as this particular peritoneal reflections that is present in it. Get it? So that's why this is very important. That's why it is tested in examinations. So what is the gastrosplenic ligament or gastrosplenic fold of peritoneum? It is nothing but a peritoneal fold which is existing between the left portions of the greater curvature of the stomach and the hilum of the spleen, which holds this short gastric blood vessels and left gastroepiploic blood vessels. It supplies this particular fundus of the stomach and supplies the greater curvature of the stomach. So this is immensely important to secure this before doing any surgeries. Another peritoneal fold exists in the spleen or related to the spleen and the kidney. Second one, we call them as splenorenal ligament, which is existing between the spleen and this kidney. So left kidney on the side, left side, and as because hilum of the spleen holds another peritoneum fold, which we call them as splenorenal ligament, also known as lienorenal. This is an old name, lienorenal. We call them a splenorenal ligament. So it holds this blood vessel, we call them as splenic vessels, which is present in it. And along with that, it holds a tail of the pancreas. Now this particular thing again very important. During splenectomy, again same surgery you are doing, not securing this particular peritoneal fold. What is going to happen? You are going to rip these blood vessels. Not only that, you are going to rip this particular tail of the pancreas. What happens if you remove the tail of the pancreas, which is the site for this particular islets of Langerhans? This islets of Langerhans is a production house for the hormones, which is regulating our metabolism of carbohydrates. So we have this particular intermediate threat to this particular person to become a diabetic person. So type 2 diabetes or post-operative diabetes mellitus could be a possibility if you have not taken care of the surgery of the spleen and not taking care of this particular fold of this peritoneum. We call them as splenorenal ligament. Understand why this is important? So this particular context, if you know that why it is important, what coming to you, if you are not securing that, makes sense and you can remember it better, right? So this is what this particular peritoneal folds is important, rather super important. So all these regions of the splenic surgery, you have to know this particular region really well. If you remove this or damage this tail of the pancreas, if you remove this particular splenic blood vessels without securing this particular tail of the pancreas, we have this particular problems which is related to this injury to the tail of pancreas, eventually leading to the diabetes mellitus. So this is what is explained why question comes here. So if you have the surgery related to the spleen surgery, we call them a splenectomy surgery. So after splenectomy surgery, a patient is suffering from diabetes mellitus. Explain how and explain why. So this is how we are going to say. So for that, you have to explain this normal anatomy. Then you have to say that during surgery it must have something happen to this particular point. If you have uttered this single word, this particular ligament, which contains this particular tail of the pancreas not taken care of, that leading to damage to the tail of the pancreas, loss of this islets of Langerhans, leading to this particular diabetes mellitus, or prone to have diabetes mellitus to this individual. So, this is how this particular explanations comes here with this. The third variety of the peritoneal fold, which is again very important, we have learned about. We call them as falciform ligament. The word falciform means sickle. It looks like a sickle, half moon. So, this particular falciform ligament looks like a sickle or looks like a half of a moon. So, this particular sickle shaped structure that you have already seen, it is a kind of like a greater omentum. It is placed between the lesser omentum and this anteroabdominal wall. So, you see that this particular region which you see here, this particular peritoneum fold is a kind of developmental remnant which is present in here, over here. So, this particular peritoneal fold exists here from this particular anterior surface of the liver, moving up to this particular undersurface of the diaphragm and falling on anteroabdominal wall till this particular umbilicus. So, this particular peritoneal fold which is extending or stretching between this part, we call them as falciform ligament. We have seen this dissection as well. Now, what does that contain? It contains this particular ligament of teres hepatis. So, it contains this particular developmental remnant, we call them as ligamentum teres or ligamentum teres hepatis, and along with some veins we call them as paraumbilical veins. These paraumbilical veins creates a bypass between the portal veins or portocaval venous system. So, when the portal vein comes as a theory lecture, you will talk about this particular paraumbilical vein, importance of this paraumbilical vein in this particular portal systems. So, this particular falciform ligament extends between this particular liver anterior surface, splits this ligament, splits the liver into right lobe anatomically and the left lobe anatomically, and this particular falciform ligament moves up and attaches to the undersurface of the diaphragm, and this particular thing holds down as this particular flaggy thing and attaches to the anteroabdominal wall. And what does it contain? It contains paraumbilical veins and it contains ligamentum teres. Now, what is ligamentum teres, which is another peritoneal fold? So, this particular ligamentum teres is an obliterated umbilical vein on the left side. So, we have an umbilical vein in fetal life we had. So, this particular fetal life umbilical vein we have lost it during the process of evolutions or development, but anyways that is a developmental part. So, that particular leftover part of the left umbilical vein remains as a ligament holding within this particular falciform ligament, running between this particular liver, undersurface of the liver, and to this particular content remains as a content of the falciform ligament. So, this ligamentum teres hepatis present as going to this particular liver. When you are going to see the liver, you will going to see this particular ligamentum teres hepatis, which is also known as round ligament of liver, which is a developmental remnant which is remaining as developmental remnant of the left umbilical vein obliterated. So, which remains as this particular ligamentum teres, which runs as a content of this falciform ligament. So, this content as well we will gonna see whenever we are going to see this particular liver. The fifth one is another remnant, we call this as ligamentum venosum. What is ligamentum venosum? There is another vein which is obliterated, we call them as ductus venosus. So, it is a ductus venosus is a venous channel shunt present in the embryonic life, which also becomes disused, atrophies and becomes a ligament. So, this ductus venosus remains as a groove within this particular hilum of the liver around that particular part. So, this particular fibrous remnant of this particular ductus venosus also forms a fold of the peritoneum buried within this particular liver substances. So, we call them as ductus venosus or groove of ductus venosus. That part has a ligament T30 part, we call them as another fold of the peritoneum. The last not the least, we call them as coronary ligament also known, and this particular coronary ligament folds here joins to form this particular triangular ligament. Now, related to the liver, we have this particular peritoneal fold. See this particular liver, this is the right side of the liver, this is the left side of the liver, and you are looking at the liver from the top side, superior side, and this is the inferior side. You have this gallbladder holding here. So, this yellow one is ligamentum teres hepatis, also known as round ligament of the liver. Now, this one is ligamentum venosum. This region we call them as hilum of the liver. So, out here we see that this is the opening from the inferior vena cava, this blue one which you are seeing here. Now, on the right side of this particular opening of the inferior vena cava, there is a stretch of irregular region on the superior surface of the liver which is non-peritoneal. This non-peritoneal region of the liver we call them as bare area, and this is a large region of the bare area bare, this is a large area in the liver, we call them as the bare area of the liver. What is the bare area? This region of the peritoneum, this region of the liver do not have any peritoneal covering. So, this rest of the liver is covered by the peritoneal, that means it is intraperitoneal organ except this bare area region. What happens in the bare area region? We have a fold of the peritoneum which is present as a margin here. We call this margin over here as coronary ligament. It has got two layers, superior layer and inferior layer of coronary ligament. This is superior layer and inferior layer of coronary ligament. The superior layer and the inferior layer of coronary ligament moves up and attaches to or anchors to this particular undersurface of the diaphragm. So, this particular peritoneal fold which is present in here moves up as a triangular fashion, joins here and anchors to the undersurface of this particular diaphragm. We call this as right layer and left superior layer and inferior layer of coronary ligament fusing to form a triangular ligament. So, this particular region which is not having any peritoneum, we call them as the bare area. When you are going to see this particular liver as an organ specimen, we are going to see this bare area, and we ask about why this is non-peritoneal, because having attachments of this particular. So, if it is liver out here, this particular region of the liver have got a area which is non-peritoneal, NP, and this particular non-peritoneal region has two layers coming like this and anchoring to the undersurface of the diaphragm. Now, while they are coming here and uniting here and forms a thready ligament. So, this thready part of this particular fused right and left coronary ligament, we call them as triangular ligament. Now, if it is present on the right side, we call them as right triangular ligament, and same thing happens in the left side as well. We have this particular left triangular ligament. So, right and left triangular ligament is present. In the right side, we have this particular triangular ligament formed by the fusion of these folds. These folds we call them as coronary fold. Now, there are two folds are there, one is this one, other is this one. We call them as superior layer and inferior layer, merging together forms united together as a triangular ligament on the right side, and this particular triangular ligament tucks in under surface of this diaphragm. So, this region we call them as bare area of liver. When you are going to learn this particular bare liver as an organ, you are going to see this particular liver bare area as well. You have to identify this particular bare area, and we ask about why this is non-peritoneal, why do not have peritoneum there, because we have this particular peritoneal non-peritoneal region because of these particular attachments of the ligaments, which is a peritoneal fold. We call them as coronary ligament, superior layer, inferior layer coming here forming this particular triangular ligament which is present in here. So, these are 6 different peritoneal ligaments which are related to this particular peritoneal or peritoneal content. So, you have to know these particular names of it, what the importance of it as far as content of it, which you have to keep in mind. Now, other entity or other modifications we call them as peritoneal folds. This is the last thing before we move to the next class. So, peritoneal folds, again modifications of this peritoneum which you are seeing here. So, some of the region of this particular abdominal cavity, some regions or some parts of this parietal layer have some kind of bends, some kind of modifications we have learned about. So, this kind of modifications we call them as folds. In case of this abdomen, we have this particular anti-abdominal wall. So, you see this particular picture is that this is the abdominal cavity which is opened. So, this is abdominal cavity opened and you are seeing this particular parietal side. So, lift open, you are looking at this inner side of this particular anti-abdominal wall. So, outer side you cut it and flip it and you are looking at the inner side. So, this is the anti-abdominal wall, this is the peritoneum which is attaching here, we call them as parietal peritoneum. So, this particular parietal peritoneum have got some folds over here in the umbilical region. So, there are 3 folds are there in this particular umbilical region, we call them as umbilical folds. So, this particular umbilical folds are 3 of them. One is strictly on the midline, one is away from the midline and third one is farther away of the midline. So, we call them as 3 umbilical fold as median umbilical fold as N median, then we call them as medial, the lateral one, medial umbilical fold, and then we call them as lateral umbilical fold. So, we call them as median umbilical fold which is strictly in the midline. So, just A1 midline fold if you are going to see, we call them as median umbilical fold. If you are going to see this black line which is B representing here, we call them as medial or L umbilical fold, and the third one is the red one represented as C which is present on the further lateral side, we call them as lateral umbilical fold. So, this particular folds of this particular peritoneum which is present or related to the umbilicus, which is present or holds some important content. So, what it holds? Median umbilical ligament holds the apex of the urinary bladder and remnant of it, it holds here, we call them as urachus. So, what is urachus? When you are going to learn this particular embryology of this particular region, we are going to talk about urachus, and there is a number of clinical interesting importance of this urachus is there. So, if urachus, which is a communication with the urinary bladder to the anteabdominal wall, if these things are present, that the patient may be leaking urine through the anteabdominal wall. So, that is an important concern over here, but anyways that is the embryological content. If we have a scope later on, we will talk about this. So, this is the median umbilical fold which holds a important content as urachus remnant as a fibrous remnant. Normally this particular urachus becomes fibery and it remains as it is there. Next to that, the B1, the second one, we call them as medial umbilical ligament which is present on the right side and left side, two of them are there. They hold this particular present on the sides of the urinary bladder, they hold this particular obliterated umbilical artery. So, this particular obliterated umbilical artery does not have any significance as in dead tissue or kind of like obliterated tissue within this particular fold. The third one which is important for us, which we call them as lateral umbilical fold. This particular lateral umbilical fold present on the right side, left side, it is very important landmark for doing surgery in this inguinal region, especially the hernia. So, if you are going to do the surgery on the hernia, it is present on the medial side of the deep ring, and this holds this particular blood vessel, we call them as inferior epigastric vessel. So, this particular inferior epigastric vessel which is present on this region, we call them as lateral inguinal fold. This one we call them as medial umbilical fold, and strictly on the midline from this urinary bladder we have this urachus. So, median umbilical fold, medial umbilical fold, and then we have the lateral umbilical fold. Out of these 3 umbilical folds, this middle one has got embryological importance, we call them as median umbilical fold, holds the urachus, clinically important for explain why kind of question, and this one lateral umbilical fold holds this inferior epigastric vessels, important landmark for doing surgery in this region, lateral just side on the side of this particular deep ring, medial side of the deep ring, this vessel can be found, an important landmark for doing surgery in this region of inguinal repair surgery for the herniations. Other peritoneal folds which is related to this particular peritoneal cavity. So, you see that this is a cross sections of this female individual, this is a cross section, sagittal section of this particular male individual. So, this region we are seeing this pelvic region. So, we have a cadaver, yesterday we discussed or seen this particular entity in the female subjects. So, we are in a female subjects in the pelvic cavity, we have 3 organs placed from front to back. We have the urinary bladder, then we have the uterus with this vagina, and then we have this rectum. So, in between this particular rectum, uterus and this urinary bladder, we have some space existing here where this peritoneum is dipping and climbing up. We call this as peritoneal folds. So, in case of the female subject, we have 2 such spaces there as this particular dips going in and coming out. So, this particular peritoneum dropping here between this rectum and this particular uterus out here, we call them as recto-uterine fold. This particular recto-uterine fold or recto-uterine space which holds within this particular peritoneal region is very important for us to do in intervention surgery or clinically very important. So, we call them as recto-uterine fold. This is marked with this red arrow here. So, this is the posterior side, this is the anterior side, this is the symphysis pubis, this is the urinary bladder, uterus, rectum. So, between the rectum wall, anterior wall and this posterior wall of the uterus, we have this recto-uterine fold. also known as rectovaginal fold. Between the rectum and vagina they are existing. So, this particular fold or this particular space which is there, we call them as pouch of Douglas, right. Now, the second one, between this particular uterus, you see that this is the anterior part of the uterus or anterior margin or anterior surface, and this particular urinary bladder which has a superior surface which is going to the posterior side. So, between this particular superior surface of the urinary bladder or roof of the urinary bladder and this anterior border or anterior surface of this uterus, we have another space. This one is little congested, little small. So, this space which is lying in here is present between this uterus and bladder, we call them as vesicle. So, we call them as uterovesical fold. Uterus and vesicle means bladder. So, uterovesical fold and rectouterine fold, these are the two peritoneal folds present in the pelvic cavity of this male of the female individual. Compare it with this particular male subject, we have only one space in this male subjects. This is anterior side, this is the posterior side, this is the rectum, same thing, and this is the urinary bladder. This is the cavity of the urinary bladder. So, this is a coils of small intestine which is cut here. Now, you see that between the rectum and this particular vesicle or bladder, we have this particular space marked with the black shadow. So, we call this space as rectum and vesicle, we call them as rectovesical fold of peritoneum which is there, and the space we call them as rectovesical space. So, these two space which is present in the pelvic cavity, within this particular pelvic region we are going to see this particular peritoneal fold, and this fold which is present on the anterior abdominal wall inner side width. So, inner side of this anterior abdominal wall we have these peritoneal folds, we call them as umbilical fold related to the umbilicus, median, lateral, medial, and in this particular peritoneal cavity we have a peritoneal fold which is existing within this particular pelvic cavity, we call this based on male subjects and the female subjects. So, in case of the female subject we have two peritoneal folds existing, whereas in a male it is one subject which is present in here. Rest of this particular content or this particular importance will be covered in the pelvic lectures, or we will be seeing that in this particular aspect. So, whenever you are getting a chance to see the female subjects, female cadavers which is present in our system as well. So, you just like try to identify these particular spaces, and we tag these particular spaces as well for identifications. So, this particular peritoneal folds which is present in this particular male individual and a female individual, we have to learn about, care about. So, to summarize, we have this particular peritoneum which have got some kind of changes, we call them as modifications. So, we classify this modification based on some kind of different changes there. Some of them we call them as reflection, some of them we call them as a ligament, some of them we call them as folds. So, we should be precisely knowing what are the folds, what are the reflections, and what are these particular folds, ligaments there, and number of that you have to keep in mind, just like a 2-liner, 3-liner, 4-liner content you have to know. Importance of that thing, clinically what part is important, why this is important, you have to justify it and read it, study it and memorize it accordingly by telling others. Like if you read something, please share with your friend whenever you get an access to him or her, just like tell about this particular, these are the folds, these are the contents, like that. So, it basically reinforces your memory or learning. So, just like learning things and holding to yourself is not going to make this particular memory last longer. So, if you want to last this particular memory for a longer period of time, share with your friends whatever you are, whatever you have read, whatever the content you have forgotten, or just like ask about it, right. So, this particular peritoneum folds or peritoneal contents or reflections or modifications are very important for examinations. So, prepare them very well for examination. Next day we will talk about the spaces and importance of the spaces we will talk about. That is it for the day. Thank you.